Vietnam Veterans of America. They have a number of projects in Cambodia and so forth. Handicap International is pulling out, which leaves the ICRC. And they have projects, prosthetic projects now, workshops, in 35, 40 countries. And in one of them, in Kabul in Afghanistan, where good colleague Alberto Cairo has been living for the last 20 years, 20, 25 years, and he's been nominated for Nobel Peace Prize. And has helped set up a half dozen prosthetic workshops. He then developed a program of microcredits for paraplegics and amputees. First of all, most of the workers working in the prosthetic workshops are themselves amputees. So that the new victim who comes in, missing a leg, and is wondering what the hell is going to happen to me in what is already a poor society, with very few possibilities of employment, etc. And what does that person see? Amputees who are manufacturing the artificial limbs. So that helps. And there's a great deal of resistance usually from many amputees, even the idea of wearing an artificial limb. Most of them want to simply stay at home, inside, and not go out and deal with the public. But when they go into the workshop, when they see people walking around, running around, playing basketball and football, soccer, not American football, playing soccer, and in Angola, another country with a great many landmines, there is actually a full soccer league where all of the players are amputees. It's like the Paralympics. So that sort of example helps the victim to reintegrate. So it's not just a question of physical rehabilitation, it's also a question of socioeconomic reintegration. And the last slide, what Courtney mentioned. Mental health integrated livelihood. That's all about socioeconomic reintegration. That's always about becoming again a productive citizen of your society. As a doctor, I have seen victims of torture and rape, both male and female victims of rape. And I've had to deal with them as a doctor. I will deal more with the question of rape this afternoon in my keynote address, but I've worked in the hospital in Paris with Dr. Mkwebe before it became well-known problem of rape. And the whole problem then of why rape occurs as a method of warfare. Well, part of it is the generalized war of men against women around the world. And so you have rape in every country, every society in the world. And I call it the general global war of men against women. In a war zone, the idea is to humiliate your enemy. And so you rape the woman in front of her husband and children. And then you rape the husband in front of the family. Now, in a traditional and socially conservative society, the role of the husband, the father, is to protect the family. You rape him in front of the family, you have destroyed the basic unit of society. And that occurs throughout history. It's nothing new. And you have to then imagine what happens to the many thousands of people living in villages in a traditional society who, being the victims of rape, humiliated, are then ostracized. In some societies, a woman who is raped is expected to commit suicide. And that she has brought shame on the family. You say, but just a moment, she didn't ask for it. She is the victim. But the idea of family honor is such that even if she is a victim, she is then expected to save the family honor and commit suicide. That's the case in Afghanistan. And it has nothing to do with Islam. It has everything to do with Pashtunwali, the traditional honor code of the Pathan people. And that is deeply ingrained in society. And therefore, the intervention is obviously not at the individual level. You have to intervene somehow differently at a society level. And it's not a question of simple mental health. It's mental health integrated into livelihood, integrated into how a society looks at itself. And therefore, it's not a humanitarian problem. It's a political problem. It's a political problem dealing with human rights in a society. As an observer, I've also seen the problem of child soldiers in Liberia, Sierra Leone, or the Lord's Resistance Army in Uganda. And what you have is children who are basically kidnapped, and they're forced sometimes to kill their own parents, or their neighbors, relatives. And a great deal of publicity has been brought around this. And in most cases, the best response after demobilization of these child soldiers is to give them a soccer ball and put them back into school. And they become children again. And you'd be surprised how quickly the vast majority overcome that mental violence of having killed as children. Children are very plastic. They're like rubber balls. Drop them and they'll bounce. But that also goes for their mental health. Give them a soccer ball, put them back in school, and in a relatively short time, they've forgotten all about everything else that has occurred. There is a minority that, yes, still has problems. Courtney talked about that minority remains with problems and needs intervention. But for the vast majority, simply reintegrating them into society is enough. In war zones, like any society, there are also psychiatric hospitals. I mean, there are people who are psychiatrically ill, and they are under medical treatment. Schizophrenia, what have you. In Iraq, there is one major psychiatric hospital, Al-Rashid. And during the American invasion, the inmates, 1,000 patients, escaped from the hospital. And it was a problem getting them back in. Now, amongst those people, you have psychopaths. Violent schizophrenics, and they are psychopaths. And in the mess of Baghdad in April 2003, with all of the looting going on and everything else, we were running around trying to find the inmates and getting them back into the hospital, using the neighbors, because after a day or two, the patients were hungry, so they went back to the hospital, and we brought food to the hospital. And the word went out, and you don't need Facebook or tweeting for this. In traditional societies, there's a network where the news gets out. There's food in the hospital, and the patients started coming back. And we managed to find a good many of them, although some of them never came back. The chronic stress, and I'll end with this. The chronic stress of a chronic war. I spent 10 years in Lebanon. The Lebanese Civil War went on for 15 years. Now, imagine, for 15 years, every other day, there's shooting, there's bombing somewhere. That's what the news is about. That's what, and you live with it. You learn to live with it. There were discotheques open in Beirut in the middle of the Civil War. Life goes on. And people simply become accustomed to a higher level of social violence. In the United States, you have the same thing. Your murder rate is not as high as Honduras or Venezuela, etc., but it's still one of the highest murder rates in the world when compared to Europe. You have become accustomed to that level of violence. And even when you get an acute exacerbation, the killings in a school or a university, what do you do? Everybody screams and shouts for a couple of days, and then life goes on. So what you have is, you have to understand that it's not just disasters. And it's not just armed conflict. Replace the word here, disaster, with poverty. Poverty appears to produce deleterious consequences on nutrition, education, health, and many income-generating processes. Furthermore, some of these detrimental effects are both large and long-lasting. And then take a look at your own society. You don't have to look only at the slides that Courtney showed you of areas of the world at high risk for disasters and high risk for armed conflict. And she said these are usually poor countries. Look at the poor in your own society and look at the effects that that will have and the mental health effects that it will have. And for any of you who are old enough, remember over the last 20 years how many psychiatric hospitals in the United States have closed down for lack of funding. And what happens to the inmates? How many of them are homeless in the streets of your major cities? They are psychiatric patients. They are poor, and they are homeless. So mental health problems can be an emergency not only in natural disasters, not only in armed conflicts, but in our wealthy, industrialized, postmodern societies as well. And that's something that we also have to keep in mind. Thank you.
So, my name's Dan Savin. I'm a psychiatrist and working at University of Colorado. One of the reasons I wanted to speak last here is because I recognize that the medical model, which you may think a psychiatrist, you know, working at a major like medical center in the Denver area, that's like the pinnacle, that's like the top of that pyramid there. Right there with specialized services. But I do understand that most of the psychosocial consequences of disasters or war are not solved through specialized medical services. And in medical services, I'm including social workers doing therapy, or I'm even including like lay people who are trained to do CBT. That's kind of like a specialized medical type of thing in my mind. Any type of medical treatment or any type of individual treatment. I believe that the main causes for the psychosocial distress are psychosocial causes. So in working both, I have worked in a refugee camp as a psychiatrist and a general physician, and post a disaster, a hurricane in Nicaragua. There's two main things are needed for rehabilitation, the way I'm dividing it. And you could even divide it into one, but I'm dividing it into two. And they are, number one is safety, and number two is economy and economic development. So you could include, sometimes in my mind I include economy in the safety category. But so if you talk with people, you know, what I've seen in a refugee camp and also in my own clinical population at, you know, where I work in Denver, safety is a main thing. Like, so you can't really, you have to stop. If there's like a war going on, you know, that's the best thing, obviously. It's going to be a political solution where people aren't fighting each other. And then if people are living safely, the degree of symptomatology, mental stress is going to go down, and their economic development's going to go up because you know, it's hard for a whole economy to work well in the context of a war. Certain parts of the economy can work well. There's, you know, contraband and black markets and things like that, but everyone doesn't really profit from that. It's you know, a minority. So safety's the first thing, and economic development's the second thing, I would say. So, and that's in the broader context, but I also look at that in terms of my own clinical practice. I think what I'll do is add a little, like, case example where, you know, where we can look at this pyramid, because I think it kind of works not only for a big community and public health standpoint, but also for individuals. So here in Denver, we see refugees from many different parts of the world, many of the different parts where Dr. Giannou has worked. We have a lot of refugees from Iraq right now, Afghanistan, Eritrea, some of the, then we have groups from Bosnia, and then older groups from Southeast Asia. Those are some of the more common groups, and Iran also. So we have about 2,500 that come to the Denver area each year. So a certain number of those clients get referred for specialized mental health treatment. So I've seen this one patient I've seen for probably it's getting on towards 12, 13 years. And he came to the United States, well, you know, just before September 11th, I think, is when he came. He came from Lebanon. He had been in Lebanon for about 15 years, but he's originally from Iran. And he spent about 4 years in prison in Iran because he got interested in political things and started sending out pamphlets that were against the government. So that got him into prison for quite a long time. Then he fled to Lebanon. He eventually got out of prison where he was tortured, extremely tortured, I will say. And then he lived in Iran for about 15 years, got married. Then he spent another like 4 years in prison in Lebanon because there were groups friendly to Iran in Lebanon who controlled different parts of the country, and he got to the wrong part of the country and didn't have any paperwork or citizenship, anything like that. So he got put into prison for another 4 years, you know, before he was finally released to the United Nations. And so when he came to the United States, he was referred, well, they tried to put him in some jobs and things like that, and he kind of failed. And the reason he failed is because he just got upset with everybody, anger, upset, and you know, which is a common thing you might see from someone who's been tortured a lot. And he was worried. He didn't trust the people who were trying to help him. That's what he basically didn't feel safe. So he would get upset very easily. And people who were trying to help him kind of got frightened. So when he first came to me, I have to say, so understanding trauma, he did have post-traumatic stress as well as depression, head injuries, you know, to some degree, although he was still a smart guy. He must have been like a really smart guy before, but you know, I think he did have some head injuries. So the first thing I start to work on, really, even though I'm in a medical setting, and I know something about post-traumatic stress and you know, how to treat that in individual therapy, he doesn't want that kind of thing right away. What does he want? He wants like safety. So what does safety entail? And economic, because now he's got kids. He's got kids that he didn't even know. because he was in prison for, while they were, you know, growing up to be 3, 4 years old. And he wants to be able to provide for himself and his family, and he's desperately afraid that, you know, they're not going to make ends meet. So my initial job is basically as a broker. I realize he's paranoid of, you know, all these people who are trying to help him, talk to him, sit there, make phone calls, to call the, you know, the case manager, I have all kinds of phone numbers in here in my cell phone here, phone numbers of social service agencies, schools, medical people, lawyers, immigration lawyers, things like that. So a lot of times when patients come in, that's what I'm doing first, really, is looking at those safety issues. And when he saw me doing that, he really calmed down a lot. And he started to trust me a little bit more. And I think that was really essential. And you would think, well, why is the psychiatrist doing that? Well, you know, the other people were trying to do that too. But I find that I really, without keeping that in mind, I can ask people's assistants to help me. You know, and once, you know, we'd bring the case manager in and he could begin to trust the case manager, that case manager would help, was able to help more. But I find that, you know, it's pretty time effective once I have all those phone numbers in mind, and I know the network of people that helps refugees in Denver, and I think they kind of trust me to some degree, you know, with, you know, that when I call them, it's not just nothing, you know, so they have trust in me. It's a building trust in this whole kind of network. And then the patient begins to have trust in me, and then he gets a little more services, a little more, you know, maybe he gets food stamps, maybe he gets Medicaid, where he couldn't have health care before because he gets too angry with people. He can't fill out a form, you know, and he doesn't know the language. He thinks people are asking him to sign things that don't really, you know, help him that much. So there's that income generation there, and housing, those kind of things are important. And then there's also, so the safety thing I want to say is when refugees, even they come to Denver here, a lot of times they go to areas where, you know, they're not the safest areas sometimes, and there's places actually, parts of the city where there will be shooting, you know. You can hear guns on a daily basis. People get really scared, you know, and so, and it's really hard to treat that. You can't really treat that. The only thing you can do is listen and understand they're afraid, and then help them if there's some other housing project or something they can go to. So that can be helpful. So the social services aspect, I think, is probably the most important part of recovery, not only for the general population, but even for the people that have a lot more trouble than most of the population. Then there are specific treatments for people who are suffering more, like the patient I talked about. You know, we do all kinds, you know, I talk with him, you know, weekly or every other week for quite a few years, and he gradually developed trust, tell me his story, and he had amnesia really of a lot of parts of his life and things that happened to him in prison, and he believed that when he'd go outside, someone would talk to him bad, or he'd see someone that looked like, or he went one time he went to an Iranian doctor, and you know, obviously that Iranian doctor's with Ayatollah Khomeini, something like that. And with time, he found out, no, he's not. This Iranian doctor's just trying to help me. You know, he's doing his best. But so the trauma would come up in his mind, and due to recent events, we talk about that and talk about how it reminded him of these other things that were happening. back when he was in prison, and he'd get an awareness that, you know, be able to differentiate the past from the present. And in the meanwhile, he'd become more involved in daily life, helping his kids out, which he really did, you know, get a lot of enjoyment out of that. And he, you know, was able to, over the years, really engage in his kids' education. He was never able to work. We weren't able to get him into a work setting. Work settings are important, they're good, but you know, people are coming to a new country, and often you see, like someone say that's middle-aged, and they have all kinds of physical injuries like this guy did. So their English isn't good enough to work in an office, and their body really isn't good enough to do manual labor. So he was able to, he is one person that was able to engage in the social service system. He was good at managing his money. So he was able to live on kind of a low income and live kind of well, take advantage of all the city had to offer. And they did integrate pretty well the family into life in the U.S. So he got some kind of medical intervention, and including medications. He still takes, you know, all kinds of medications to help him sleep. I try to decrease it some, and he says no, and we go back and forth, and then, you know, gradually we decrease a little bit. But
medical marijuana in Colorado?
We got a lot of medical marijuana in Colorado. I've had patients that have used it. I don't really recommend it. I haven't really seen any of my patients that have done really well with it, but I have had a number that have used it.
Also non-medical marijuana.
We have non-medical marijuana. The kids, you know, the kids like, they like to use it. So that's an example of like an individual case. So I'm hoping that you can get an idea of this pyramid from public health efforts all the way to, you know, one individual case.
Well, thank you all. That was really great. And very fascinating to see points of view from different specialty areas of experience. So the panelists were wondering what experience is in the room here and what people in the audience have worked doing psychosocial interventions, either domestically or internationally, and sort of what are your opinions on what you've heard today?